We'll now dive into the heart of today's session with our panel discussion entitled Expanding Virtual Access to Healthcare in the New COVID Reality. Moderating the panel is Dr. Aimee Grace, Director of the UH System Office of Strategic Health Initiatives, who will be introducing the members of her panel. During the panel discussion, we welcome our viewers to send in questions for our panelists, which will be answered during the Q&A session to follow or at a later date on the conference website. At this time, I'd like to welcome Dr. Aimee Grace.
Good morning, and thank you so much for joining us today for our conference and our upcoming panel entitled Expanding Virtual Access to Healthcare in the New COVID Reality. Thank you to Dr. Kim and Dr. Fox for those fantastic presentations. Dr. Fox just stressed the importance of deep, meaningful collaboration and partnership to improve health and healthcare. And I'm glad that we'll be able to share those types of stories with you today about virtual care. The COVID-19 pandemic has significantly accelerated the transition to virtual healthcare. While telehealth advocates in Hawaii and across the nation have worked for years to address many barriers to expand telehealth, including Medicare reimbursement, licensing, credentialing, broadband access, and provider and patient acceptance, the COVID-19 pandemic created an environment where the use of telehealth skyrocketed in a matter of weeks. The loosening of federal restrictions, shift in provider and patient willingness and capacity to try telemedicine, and boost in funding for telehealth initiatives certainly contributed to this expansion. While many patients and providers have adjusted to this new normal, many issues remain, including whether systemic restrictions will remain lifted going forward, how business plans and workflows will adjust to accommodate telemedicine in the future, the digital divide and pursuing health equity for underserved populations, and how we train our future health workforce about telemedicine. I'd like to start our panel by giving context to a few terms. Telehealth is defined by the National Center for Connected Health Policy as a collection of means or methods for enhancing healthcare, public health, and health education delivery and support using telecommunications technologies. We generally think of telehealth as the broader, more encompassing term for both clinical services delivered remotely, as well as other services like virtual provider continuing education, provider-to-provider communications, and home health. Telemedicine is a term that's often used to refer specifically to clinical services delivered remotely, for example, from a provider to a patient. Synchronous telemedicine visits are conducted in real time, like a FaceTime with your provider. Asynchronous store and forward telemedicine is used for when, for example, you might take a picture of a mole and send it on to your primary care provider or to your dermatologist to review at another time. Remote patient monitoring is a way to use digital equipment to monitor patients' vital signs at home from afar. There are many other terms related to telehealth, but that should start us off. I'd now like to introduce each of our amazing speakers for this morning. Dr. Matthew Koenig is the Medical Director of Telehealth at the Queen's Health Systems and Associate Professor of Medicine at the UH John A. Burns School of Medicine. Dr. Kris Wilson is the East Hawaii Regional Chief Information Officer in Hilo for the Hawaii Health Systems Corporation. Dr. Christina Higa is the co-director of the UH Pacific Basin Telehealth Resource Center here at UH Mānoa. And Dr. Buenconsejo-Lum is the Associate Dean for Academic Affairs at the UH John A. Burns School of Medicine and Professor of Medicine, Family Medicine, and Community Health. We'll be talking in this panel about telehealth in Hawaii in different sections, pre-COVID, during COVID, and then looking forward into the future. So thank you so much for our panelists for joining us today. I'd like to set the stage for our conversation about virtual care to first understand what clinical care was like before COVID and how we were using telehealth then. I would ask that each speaker please introduce him or herself, and then please speak from your vantage point about the areas of capacity that existed in our state prior to COVID-19 and what barriers existed before COVID in regards to telehealth. I'll start first with Dr. Christina Higa.
Thank you, Dr. Grace. Thank you, Aimee. Hi, everyone. I'm Christina Higa, the co-director of the Pacific Basin Telehealth Resource Center and a UH alumni. PBTRC is based at UH Mānoa. We're under the Social Science Research Institute of the College of Social Sciences. And we're one of 14 telehealth, federally funded telehealth resource centers in the country. PBTRC serves the state of Hawaii, but also the Pacific Islands. We serve the territories as well as the freely associated states. We don't provide direct clinical care, but we work with healthcare providers and systems in Hawaii and across the Pacific to advance telehealth. And the way we do that is we work on policy development, business model development. We help with equipment selection and also collect overall best practices and training. So now going to the second part of your question, Aimee, of where we are with telehealth prior to COVID. Well, PBTRC is not a new organization. We're actually established 10 years ago, but most of our work until more recently was focused on telehealth policy. And many of us collectively, many of us on this panel have spent years working to try to promote telehealth, including Dr. Aimee Grace, who played a key role in Senator Schott's office at the federal level. And adoption was slow for years. It doesn't really make sense because telehealth seems like a natural fit for our island state, where the majority of health specialists are concentrated in Oahu, Honolulu specifically. But really, probably about 6 years ago, we had less than 5% adoption of telehealth of our healthcare providers. According to a AHIC study, it's actually 2% adoption, so very low. So we brought stakeholders together, and when we listened to the stakeholders, we heard a broken record. It was the same message for years, really, that people didn't understand if they could get paid for telehealth, and if they could, how much. There was a reimbursement issue. There was uncertainty about malpractice insurance coverage and other concerns, like, there were so many requirements of where the patient was. They needed to be in a health center and in a rural area. So basically they couldn't be getting their telehealth services from home, which is very prohibitive. So it was really clear that we really needed to change policies and to fix these major problems. And Senator Baker took all of this feedback and introduced a bill that was signed into law by Governor Higa, and that's Act 226-16. That's our telehealth law. And we should be really happy to know that it is still known as one of the most progressive telehealth laws in the country. It lifts many of the restrictions that the federal government actually did temporarily lift some of these restrictions during this pandemic, because the federal government has oversight over Medicare, the coverage for the elderly and those that have disabilities, and the state government has oversight for Medicaid and also the private healthcare providers in our state. So Act 226, was enacted in 2017. And so back 3 years ago, we already had, some of these really great policies to enable telehealth. It required parity for payment, so meaning that you have the same reimbursement in person as if you delivered it via telehealth, It mandated malpractice insurance to cover telehealth. And it includes a very flexible definition of telehealth, including interactive and store and forward mobile telehealth. And there's no restrictions on the location of the patient or provider. So that law was passed 3 years ago, but telehealth adoption, even just before the pandemic, was relatively low at about 20% adoption. So operationalizing policy takes time, but maybe more importantly, change in behavior, change in culture. And when I say culture, I mean in the way that we do things. That takes a long time. It takes a long time, especially during normal circumstances. So in today's panel, you're going to hear more about the huge surge in this huge surge in telehealth because of COVID public health measures. But in that introduction, I just wanted to give you a little bit of information about PBTRC, our organization, and also emphasize that prior to COVID, we already had, and we still have, a very strong enabling telehealth state law, but there are federal laws that are prohibitive for Medicare beneficiaries. And as I mentioned, some of that have been lifted during the public health emergencies, and something that we are still tracking to follow to see what will happen after the public health emergency. Back to you, Aimee.
Thank you so much, Dr. Higa. And many in the community have found how incredibly valuable UH's Pacific Basin Telehealth Resource Center has been during COVID and far before. So thank you so much for all that work. Let me turn it over to focus on the clinical side to Dr. Koenig. If you could please introduce yourself a little bit more and share with us from your vantage point what telehealth was like before COVID.
Thanks very much, Dr. Grace, for the introduction. So I'm Dr. Matthew Koenig. I'm a neurologist at Queens Medical Center and a stroke specialist, neuro intensivist. And I'm also the medical director of telehealth for Queens Health Systems. And I'm proudly also an associate professor of medicine at the UH-JABSM. And I've been at Queens for 11 years. I moved here from the East Coast. And one of the reasons one of the projects I had in mind, one of the reasons I took the job, and I thought it would be a great adventure in my career to move to Hawaii and join the faculty and join the physicians at Queens, was to support telehealth in the islands. At the time, I had experience in my training at University of Maryland with the telestroke program, which began in the late 90s. University of Maryland at that time had one of the first telestroke programs in the country. And that allowed specialists at the hub hospital at the University of Maryland to see patients remotely at outlying hospitals and treat them for strokes. And these were small community hospitals that didn't have a neurologist available to them. And so I recognized that Hawaii was a great environment where telemedicine made sense, given the geography of the state and how remote it is, and the fact that most of the specialists are concentrated on Oahu, and especially those patients on the neighbor island, but even some of the rural communities on Oahu lack access to specialists, whether it be a neurologist or another specialist. And so for the last 11 years, I've been helping Queens build telemedicine programs, including the telestroke program. And so a little bit of background on telestroke. We actually serve 9 hospitals in the state. So my colleagues and I, when we are on call for stroke coverage for patients who have symptoms of a stroke, we're actually on call for 9 hospitals. And so over the years, that has become the normal way that we treat patients. We actually treat more patients by telemedicine, meaning video, than we do in person at our own hospital. So it really does show that within that specific specialty, how telemedicine over the years has become a very normal and established way of treating patients. And then over the last 5 years, as the medical director for telehealth at Queens, I've helped support a variety of telemedicine projects across the institution. And we categorize telehealth in 3 different ways. One is the hospital-based telehealth, where a patient is at a hospital, they're either an inpatient or in the emergency department. And telestroke is kind of a typical example of that. But we also have a small tele-ICU program as well with our hospital at North Hawaii. The second category we call clinic to clinic. And so that's where a patient presents at a brick and mortar clinic. It's like going to any other clinic like you would do in person. You're checked in by staff. There's someone to assist with vital signs, lab work, et cetera, except the specialist is remote. So the specialist is here on campus and patients are at our brick and mortar clinics on the neighbor islands. And we use technologies in order to follow up those patients. And then the third model is the direct to patient, or what we call virtual home visit, where the patient is either at home or work or at school and is using a consumer grade device like a smartphone, tablet, or a laptop computer. And then the primary care physician or specialist is able to connect with that patient either on a scheduled basis or on a on-demand or ad hoc kind of urgent care basis. And that last model is the one, we knew that's where the major growth area was going to be. And we had begun heavily investing in the technology necessary to do those direct-to-patient video visits back over the last summer. And that was about 50% of the telehealth that we were doing back in last year, 2019. But that really exploded during the pandemic, and that's I think the major growth area going forward. As Christina mentioned, this is not an easy process, and so going into the pandemic, we did see growth of telehealth occurring at Queens, as it was being seen in the rest of the state, but that growth was relatively slow. And there were a number of barriers that still existed to both provider and patient adoption. And I think we'll get into some of those issues during the panel today, but some of those barriers were regulatory and reimbursement related, especially in the Medicare payer population, and some restrictions that remain on the books in that population. But a lot of it is related to just change management and getting providers to adopt new technologies. And these are providers who are already quite busy with an in-person practice. And so having to learn a new way of doing things, especially when there's uncertainties around payment and coverage, is very difficult. And so it was a slow process getting providers to adopt. And then I think the third barrier was that, in telehealth, we talk about consumerism and we talk about consumer demand driving uptake. But the reality is that we weren't seeing a lot of consumer demand prior to the pandemic. And that, until patients were really coming and demanding or asking for telehealth visits, we didn't see a real drive in adoption until the last year occurred. So that's a little bit of background about what we're doing at Queens, and I'll turn it back to you, Aimee.
Thanks so much, Dr. Koenig. And certainly your leadership for years has been critical. As we know, the sooner stroke patients get treated with clot-busting medication when it's appropriate, the more we prevent death and disability. So having that system available across the state has been critical. And again, that's one of the major areas of capacity that we had in the state of Hawaii prior to COVID. So thank you very much for that. I'd like to turn it now to Dr. Kris Wilson. We are so honored to hear from you from a neighbor island perspective, because as we've been talking about, that's one of the areas where telehealth can be most used. So if you don't mind introducing yourself and sharing a little bit more about life before COVID in regards to telehealth. Thank you.
Sure. Thank you, Aimee. All right. So good morning, viewers and my esteemed panel. My name is Kris Wilson, and I'm the Chief Information Officer and also a hospital administrator for Hawaii Health Systems, East Hawaii region. So geographically, we're located on the Big Island of Hawaii. It's a little rainy outside today. And if you can imagine the coastline, geographically, the East Hawaii region follows the Hamakua coast all the way down to Ka'u, with Hilo Medical Center and Hilo being kind of the epicenter of the region. I've been with Hilo Medical Center for about 14 years, about the last 11 of which I've had this fantastic team and leadership that we've been implementing electronic health records and progressive technology into the facility. Our goal is really trying to connect our region, our providers, and our patients together by using this technology. And today I'm here to give you a little bit of perspective on just the rural community journey that we went through with telehealth. It's going to be a little bit different, but honestly kind of dovetails into what Christina and Dr. Koenig have already spoken about. So our telehealth journey definitely came from very humble beginnings. When I started at Hilo Medical Center about a decade ago, I was in imaging, and we had our telestroke program. And this was kind of just earth-shattering tech at the time. We didn't have any specialist on the ground here, and we were relying on either flying the patient out or phone calls to really do that consult. And what that consult looked like, and I'll frame that for you guys, is about 11 years ago, we would take this little camera off the shelf. It kind of looked like C-3PO, and we would aim it at the CAT scan monitor. And then we would scroll through images with the neurologist or the stroke team on one side and the technologist on the other side. And it was like, okay, go faster, okay, go back, and then go back again. Again, not ideal how you would like to run a telehealth program. But we did go from film, and then we went to CDs, which we thought was, again, earth-shattering. And now we have integrated PAC systems and EHR systems. And really, this telestroke program is so successful that really that patient as their images over to Queens before they even get back to the ER bay. and get off the table. So really great advancements that we've made in our telestroke program, with the thanks to Dr. Koenig, UH, and everybody that it took to kind of get us to that point. But really, as Dr. Koenig had mentioned, most of our telehealth was really focused with inpatient. So either the patient was sitting in the ER or was sitting somewhere in our acute unit, and we controlled the tech. We controlled the device that they were on, their wireless connectivity. We basically rolled a telehealth monitor into a room, and we connected them with a provider that was quite accustomed to doing telehealth on the other side. And this was all pre-pandemic, and that's pretty much what the model was for us. We were going to build a telehealth center, which we would be doing brick and mortar again, clinic. So patient comes into the clinic, we again control that tech, we control their wireless, we control their devices, and then we were able to proceed with a telehealth visit from the outside or from a specialist that was far away. And that was really what our journey was prior to the pandemic. And we were fairly successful at rolling out both telestroke. We did a number of telenephrology, and we also did behavioral health, and we were looking to expand on those services. And then the pandemic happened. And for a rural health community where everyone started to shelter in place, we wanted to take care of our patients. We wanted to minimize visitation and movement around the community. People weren't getting the care that they needed. So we started with rudimentary telephone calls and FaceTime visits. But to really encompass a true telehealth experience, we found a whole new set of challenges. And that's, I think, what we're going to talk about today in a little bit further in this discussion. But that was really our journey from having a camera come off a shelf and being pointed to a monitor to now being able to interconnect with where we are today in the middle of this pandemic. So I hope that gives you some perspective from the rural health community, and I'll turn it back to you, Aimee.
Perfect. Thank you so much, Dr. Wilson. And thank you so much for your leadership over years in our wonderful Big Island community to make sure that they have the tools they need to get the healthcare that they need. I'd like to now turn it over to Dr. Buenconsejo-Lum and ask you similarly to introduce yourself and then give us a perspective from your vantage point about telehealth before COVID.
Aloha, everyone. Thank you so much for inviting me to participate on this panel. And I'm going to speak from multiple perspectives. So I'm Dr. Buenconsejo-Lum. I am a family physician. I graduated here from JAPSM. And I served as a family physician in Wahiawa for many years. And I'll emphasize why I mentioned Wahiawa in a little bit. But as a family physician, we take care of the continuum of life, really, from birth to death, all kinds of patients from all backgrounds, all socioeconomic statuses, and all level of technology capacity and regular English literacy, much less health literacy, much less digital literacy. But I've also been in academic medicine since the beginning of my career, and I've served as the residency program director, and I currently oversee all of our residency and fellowship programs in the state. And so that's what a DIO does. And so I have been able to witness this surge of everything in relation to telehealth across all of our residency and fellowship programs and our UH clinical practices. I'm also the Associate Dean for Academic Affairs here at the medical school, which means that I oversee the continuum of medical education. So our pipeline programs, our post-baccalaureate programs, our medical students, our residents, fellows, faculty, continuing medical education, and all of these support services that go into creating a physician who will stay here in Hawaii. And then the last perspective is that, like with Aimee Grace, I've been fortunate to work with the Hawaii Emergency Management Association since the beginning of the pandemic. And so I'm the JAPSM liaison. I've helped Aimee with the telehealth assessment, which you'll hear about a little bit later. I helped Dr. Kris from School of Nursing and many of our colleagues from social work and public health who are dealing with the community care and outreach group. And so really looking at our most vulnerable populations, and telehealth is a concern for them as well. And we also have a small working group on home-based care of COVID patients. So again, care homes, foster homes, hospices, et cetera, et cetera. And so from these different perspectives, I think heard some of the challenges. And so, but the additional perspective is that I've been working with Christina since 2002 with the US Pacific. and really looking at the capacity, starting with distance learning, and then all the way and continuing and we have a panel tomorrow about telehealth in the U.S. Pacific. So why I mentioned Waihua Hospital is because we were one of the hospitals that worked with Queens, and actually even with Matt's predecessor, on telestroke and tele-ICU, and even before then, it was taking the picture of the EKG and texting it to our cardiologists, and sometimes the resolution, once you had a better camera, the resolution is better than the fax, et cetera, et cetera. So that was, some of the kind of clinical experience on Oahu, but nevertheless in a smaller community with a lot of different, resource challenges. And then on the academic side, depending on the specialty, depending on what facility, there was really various awareness or utilization of telehealth and telemedicine. And so that's, again, pre-COVID, and a lot of things, have changed since then. We'll hear about that a little bit more. But yeah, so those are, again, some of the perspectives that I bring, and I've been working with many on this panel and others on the call actually as well, to try to help improve our statewide capacity. So thank you.
Thank you so much, Dr. Buenconsejo-Lum, for your leadership, both in the clinical capacity as well as with training our JABSOM students and residents and so many others in telehealth over a long journey. So now we're going to get into a lot of the meat of today's discussion, which is what telemedicine has been like in Hawaii in the context of the COVID-19 pandemic. To start, I'd like to share the results of a statewide telemedicine needs assessment that Dr. Buenconsejo-Lum mentioned, which I had the privilege of leading for the Hawaii Emergency Management Agency, or HIEMA, earlier this year. This needs assessment was conducted in May 2020 and had more than 100 responses across the state from hospitals, clinics, independent providers, federally qualified health centers, Native Hawaiian health systems, and more. The study showed that Hawaii had significant capacity for telehealth in some areas, but large gaps in others. For example, the majority of the respondents reported in May 2020 that they recently began providing virtual patient visits and teletriage services. As we've heard, telestroke and additionally teletriage and asynchronous store and forward technology could be found statewide prior to COVID-19. Many respondents stated that they desired to start or expand telemedicine services, such as remote patient monitoring, e-consults, asynchronous store and forward technology, and real-time imaging. However, we did note that very few respondents had a lot of the equipment that could be needed for some of these types of activities. Barriers for expanding telemedicine included lack of funding, poor internet connectivity, and a lack of staff training. If you're interested, you can find this full report at uhealthy.hawaii.edu under news and events. So these survey results give us a big picture perspective of the state of telemedicine in Hawaii in the time of COVID. I'm excited to turn to our panelists to provide more color and insight into what these changes have looked like on the ground. So we're going to get into a bit quicker answers now. So to our panelists, can you please speak to how the pandemic has affected the use of telemedicine in your work and organization from a big picture and numbers perspective? Let me start with Dr. Higa.
Thank you, Aimee. So this is really fun to reflect back. I said we were 10 years old here at PBTRC, but Lee reminded me we had been working on telehealth prior to almost 20 years. So it's kind of amazing to just reflect on these numbers. Most of the big surge actually happened right in the first 3 months of the pandemic. So I do have some numbers for you. PBTRC had increased in our technical assistant requests by 465% in the last 8 months, if you compare it to March, October of last year. So just to give you a sense of what that means, in last year, we had about 17 webinars during that period. And this 2020, we went to about 50 webinars, from reaching about 1,400 participants to 3,000 participants. So the numbers just exploded. And again, as I mentioned, it was really in the first 3 months of the pandemic where we're really our busiest. However, the request for assistance, it just remains constant. Back to you, Aimee.
Thank you so much. Dr. Koenig.
As I mentioned, we had been doing some direct-to-patient telehealth leading up to the pandemic, and that was our major growth area. We thought that's where growth would occur. And we were doing about 200 telehealth visits per month in that way. We projected to do 2,500 on the whole year. And instead, beginning in April, when the lockdowns occurred and some of the waivers went into place that allowed people, allowed providers to get reimbursed for telehealth for patients in the home, we had a 65-fold increase in the use of telehealth in that manner. And so we were doing about 2,500 telehealth visits per week rather than on the whole year. And those numbers have actually increased. They've continued to increase over time. So last month, we actually did 16,000 telehealth visits in the month of October. So, rather than what has occurred on the mainland, where there was a really big increase in telehealth in the spring months, and then it kind of settled down, even though the pandemic continues to rage in those areas, there was like a settling of telehealth visits. We haven't seen that at Queens. We are actually seeing continued rise in telehealth adoption. And that really, I think, speaks volumes to this perpetuating beyond the pandemic.
Thank you so much, Dr. Wilson.
So before the pandemic, on just the inpatient side, we did about 2,000 telehealth visits per year. A lot of that was telenephrology. And then we did 0 outpatient, where the patient was in the community and we were providing telehealth from the clinic. The provider was sitting in the clinic. It was 0. We went up to 400 within the last 3 months. So we accomplished over 400 visits and climbing. And that's, again, thanks to just an amazing team that really bunkered down and said, we need to get this care out to the community. But that expansion was really historic. We currently have about 9 clinics that are live with telehealth. As you can imagine, some of the specialties, a little bit slower on the uptick, but primary care is pretty steady. And we see that the consumer and our patients are really wanting more and more telehealth. Thanks, Aimee.
Thank you so much. Dr. Buenconsejo-Lum.
Sure. Well, pre-COVID, for most of us in the outpatient setting, and certainly in the education and how we do rounds in the hospitals, that was at a big 0 prior to COVID. And in the ambulatory practices for medicine, family medicine, and obstetrics, they ramped up to anywhere between 60 to 100% of all visits being done via telemedicine really through July. And now even it's sustained about 50-50 for, again, depending on the specialty. Now, our psychiatry and child and adolescent psychiatry was different. They were already doing telepsychiatry, especially to the neighbor islands. But the need has almost doubled. And so definitely we've also seen a ramp up. And then on the actual education piece in the hospital, some of our residency programs have had to do telerounding because of the physical distancing, and we can't let them be in the ICU with a really high risk patient, but we still want to make sure that they are as participatory as possible in the care of very ill patients, including those who do have COVID. And so depending on the facility, our residents or fellows have been able to kind of join rounds by, a nurse is inside holding an iPad or some other device. And then you can engage that way. There's been a lot of different creative ways to do what we call telerounding. And then in the nursing homes as well, we have our fellows and our also residents and medical students, but in the nursing homes, there's been a huge adoption, not uniform. Some of our long-term care facilities face a little bit more challenges than others, but in the long-term care facility also, there's been a huge increase, again, all from 0.
Thank you all so much. So as you can see, really staggering, explosive growth in telehealth, and really proud of our UH partners and community partners for standing up with this kind of innovation, right, and really supporting this taking off across the state in a time of need. So I really want to hone in on clinical care. So for those of our clinical panelists, can you speak to us a bit about what were the challenges and barriers in trying to set up telemedicine so quickly as part of COVID? Dr. Koenig, I'll start with you.
Well, most of the telehealth that we had built to this point had been on the basis of early adopters, people who were true believers in telehealth. They were willing to devote their time to getting the workflows right, kind of muddling through technologies. And I would say that that's true both on the patient and the provider side. And so what happened during the pandemic is there was a forced adoption that occurred. Basically clinics were effectively closed and patients were told that if we're going to try to do it by telehealth first, and if you can't do it by telehealth, then you can come into the clinic and be seen. And so you get a lot of very interesting information about consumer preferences, what providers are willing to accept in terms of technologies and workflows. And it's not necessarily what we would have predicted based on our experience with early adopter. This was kind of like dragging in the laggards and then getting a lot of feedback from them about like what they're willing to adopt and not adopt. And a lot of our assumptions were wrong. And I think ease of use became a huge factor. We wanted a lot of bells and whistles, and we wanted telehealth to have a lot of embedded technology that we thought would support healthcare. But but I think the ease of use is a big lesson learned, and having backup plans in place. So if your initial technology solution isn't working well and the provider is struggling or patient is having trouble with the technology, there's got to be an easy, effective backup plan to connect those visits. So I think that has been a powerful lesson learned. We've taken that lesson back. We kind of re-architected our solution to make sure that we can enable those visits to occur.
Thank you. Dr. Buenconsejo-Lum, let me turn to you.
Sure. So yeah, a lot of challenges. So the first thing is that we were doing in the outpatient setting, and also somewhat in the inpatient, but I'll speak mostly to outpatient. We were rapidly trying to figure this out before the state figured it out. And at the same time that Queens and HPH and Kaiser were trying to figure this out. And so we were fortunate that we had connections in University of Washington and Boston and California and others who had to figure this out before us. In terms of teaching, because there's a lot of barriers to just having a regular providership patient, but when you add a learner in, that's a completely different workflow. Certain technologies work better for that than others, and there's still rules that have to be followed in terms of precepting or supervising those visits. So just a lot of kind of regulatory and technology challenges. And then, many of the faculty who have been longstanding teachers of our residents, fellows, and medical students were not these early adopters. And so that was a huge ramp up as well. But fortunately, everybody knew we had to do it. And so really figured it out. And then as we worked together, later, the collaborations were really important, because then as everyone was starting to figure it out, then we could share and get some uniformity. So thanks.
Thank you. Dr. Wilson.
So we had three primary just kind of initial struggles. The first was trying to sign the patient up for patient portal. So we decided to use an integrated application with our electronic health record, and that required our patients to go in and to launch the visit from the portal. And that also tried to mimic us face-to-face. And it was a better integrated process for the provider. But even though we had patient portal around for many years, we found that patients just struggled to sign up for the portal or even log in within the 72 hours that their link was still available. So patient portal was our first barrier. The second, as we all discussed, was the provider. So our providers were, and we keep saying this, they were early adopters, because the technology that we're using for telehealth had come out during the pandemic. Our electronic health record vendor actually came out with this technology as the pandemic was evolving, and telehealth visits became reimbursed at a face-to-face level. So there was some drive there for the providers to really try to get on this telehealth, get on the telehealth forum as well, because we could also start to see reimbursement come back in, even though that wasn't the primary goal. Of course, the goal was to provide care. But the provider adoption was hard. Even finding Logitech cameras was hard. I ordered 32. I think we got like 2 in. And then they have staggered in ever since. then really managing the technology from outside the facility, having the patients log in on their commercial device at home and managing their overall experience and their connectivity, their speed, their strength. And what we thought we gave out was great instructions. And then what we found out during the visit was not so great instructions. So we were continuously refining our instructions for our patients. And those were really the three major things. And it was kind of this three-legged stool that if one thing didn't happen, the whole episode or the whole visit will kind of tip over. And then how we would try to find alternate methods to then call the patient and say, hey, did you get everything you needed? So much like the rest of the panel, we were experiencing very much the same barriers here in the rural communities. Thanks, Aimee.
Thank you all so much. That certainly sounds like some formidable barriers, but also really impressive how you were able to push through those. And we know one of the ways we're able to push through barriers is through collaborations. And we at UH, and we really believe in UH as a powerhouse for the state in terms of economic development, in terms of innovation and more. But we can't do it without critical partnerships with community members and collaborations. So we're just wondering if you can speak to some of the collaborations that emerged during COVID with regard to telehealth. And Dr. Higa, I'll start with you.
Okay, thank you, Aimee. I've been really impressed with the level of collaboration taking place during this pandemic. As I mentioned before, implementation of projects, policy takes time. We had no time. We're racing against time. If you think back at the early stages of the pandemic, you remember we didn't know what the surge was going to look like of our health systems. It was actually really scary. So the work that we were all doing, it was so urgent, and people were just having to break down silos, roll up their sleeves and just jump right in, and you looked around, everyone was working really hard to ramp up telehealth. And especially, like I said, in those early stages, we really didn't know what to expect. And the virus was still new too, so learning a lot as we went. So some of the collaborations, I want to just say Aimee. I think Aimee and I spoke daily, multiple times a day, Lee as well, and it was a lot of collaboration within the university. And outside of the university, we had a lot of collaboration with the Department of Health, worked with their telehealth coordinator, but I also kind of partner up with Sylvia Mann, who's with the Department of Health Genomics section. She's also has a lot of telehealth experience. She leads up the National Telegenetics Task Force. And so we held daily and nightly meetings, reviewing policy, answering questions. And then we put together a series of telehealth hui and regular weekly office hours where we gave policy updates and conducted a full spectrum of telehealth training from planning to evaluation. This went over a period of months. We also partnered with the Hawai'i Primary Care Association. We jointly put on telehealth weekly roundtables to facilitate their peer-to-peer discussions with their FQHCs. And those federally qualified health systems, they support some of our most vulnerable populations, and they really had to convert their services quickly to telehealth, and they did. We also worked with healthcare payers, including Medicaid, and worked on a much more coordinated ways in providing each other information about the rapidly changing policies and plans. We tried to focus on the needs of the independent providers. So we work with the Hawaii IPA and also Team Praxis to keep a tab on, the needs of providers and patients and families in terms of telehealth. And more recently, we tried to focus in now as things are calming down, and we are now convening telemedicine directors and payers stakeholder group. And I'm doing that in partnership with Dr. Koenig. So I wanted to ask Dr. Koenig if he could speak a little bit to that. So I'll turn it over to Matt.
Thanks, Aimee. So I think the collaborations have been incredibly important, and not just during the pandemic. The reason that Hawaii has a very progressive telehealth law is not because that happened just organically, right? It happened because people like Christina and Deb Peters at the university convened a group of stakeholders, and Senator Brian Schatz convened that group of stakeholders to figure out as a state, like how we could get together and support telehealth, support the bandwidth necessary to do it, especially in rural areas, support the laws that were needed to make sure reimbursement occurred for telehealth within the state of Hawaii. And so that collaboration really, well predates the pandemic. For the last, 5 or more years, and Pacific Basin Telehealth Resource Center has had that convener role, where they can get stakeholders together to work on policy, work on reimbursement, work on sharing best practices to figure out technologies and how to support patients to learn to use telehealth. And so, the collaborations that occurred were really just an acceleration of what was already in place. But I think a big one was really working on what waivers needed to be put in place at the state level to enable telehealth to occur or be rapidly adopted during the pandemic. And many states did that, and there was a lot of federal waivers that were put in place. But there was a big group that got together early on, including a lot of stakeholders and payers, to figure out what should Hawaii do in order to make sure that patients are able to be seen even if they can't go into the doctor's office. So that, that's a great example of some of the collaboration that took place during the pandemic. So back to you, Aimee.
Yeah. So true, thank you. And just to mention, Lauren Kim and Laura Arcibal at the Department of Health have been really critical on telehealth and policy. So we appreciate their collaboration too. Dr. Buenconsejo-Lum, your thoughts?
Sure. So besides all the collaborations that were previously mentioned, some other key collaborations happen both statewide and nationally. So nationally, through our American Association of Medical Colleges and the Accreditation Council of Graduate Medical Education, really helped with a large advocacy push to CMS for a lot of the regulations and other things that we have heard bits and pieces about and may hear about later. And so that's been really important. And I mentioned earlier that our partnership with some of the other medical schools as well. So that again, we telehealth was not designed, medicine was not designed, medical education was not designed for telemedicine yet. But the other important role is, again, with our geriatrics department working really hard on the long-term care issues and providing a lot of training sessions in collaboration with Mountain Pacific Healthcare Quality and AHRQ and others, because as we all know, long-term care facilities are really quite vulnerable. And as we've come to learn as well, our community care homes and our foster home also, very vulnerable. And so our Department of Geriatrics and others through Haima and many of our folks who are faculty in their real day jobs have helped with those particular spaces. And then on the academic for health professions, then we have this Hawaii Interprofessional Education Program, which is really which is medicine, nursing, social work, public health, and pharmacy. And that had already been well established in terms of interprofessional education, but we certainly started to move towards telehealth. And so each of those specialties is developing their own small module. For us, we're developing a very large curriculum, but we're all working on an interprofessional telehealth module, because that is also, besides telehealth, interprofessional care is also how care should be delivered going forward. Thanks.
Thank you all so much. And we've moved from, pre-COVID and then into the reality of COVID. And now it's really time to look forward, right? I mean, we've been in this public health emergency for a while now, but what does this new reality look like? So I know we're getting a little bit short on time, so I want to just turn to each of our panelists and just ask for brief comments on what does this new reality of COVID, beyond COVID, look like to you with regards to telehealth? And Dr. Buenconsejo-Lum, I'll just come right back to you for that.
Sure. So I alluded to some of it earlier. We feel that virtual healthcare is here to stay. In some specialties, it's anticipated actually 50% of visits. In fact, that's a target from some of our health systems nationally as well as locally. And it's so much here to stay that, in fact, our accrediting organizations have developed a full set of telehealth competencies that all of our medical students, residents, and faculty are expected to achieve. So they're not an accreditation requirement yet, but that is definitely coming.
Thank you. Dr. Wilson.
Sure. Going forward, we think as well that telehealth will be here to stay, that most of our clinics will be completely outfitted with either some capacity for telehealth, where we at once thought that we were going to create kind of a telehealth center. Now all of that's dispersed through all of the clinics. We do anticipate that the consumer will be coming, or at least the consumer applications will be better in the future, that they'll be able to click on a smartphone and launch their telehealth visit. But I think that the tech will march alongside with the demand for telehealth. And we think that telehealth will just be another normal visit that you would get from your provider going forward. Thanks, Aimee.
Exciting visions for the future. Dr. Koenig.
Okay, I'm going to be the contrarian, and I'm going to say that we don't know what's going to happen with telehealth after the pandemic. And I think the important piece is that it's going to be driven by consumerism. It's going to be driven by consumer interests, and we have to recognize that. So the telehealth experience has to be a good professional experience that the patient will want to return to. What we don't want is a reactionary response to telehealth during the pandemic. And that takes investment on the part of providers and institutions to make sure that from the patient experience perspective, that visit has replaced the in-person visit, that the patient leaves that experience feeling like I have seen the doctor and I got my healthcare needs met. And so I think that's the mind frame we have to have. And it's not, I too talk about like the genie not going back into the bottle and it's here to stay. But I think that remains to be seen, and it's going to be driven by what the consumer's experience of that healthcare is. And as healthcare organizations, like we need to invest in making sure that patients' needs are met and that they have a good experience and they want to return to telehealth. So I think that's the caution I'll put on that.
Appreciate that. Important to be balanced. Dr. Higa.
Thank you. Yeah, for sure, technologies will advance, and become more sophisticated and mobile. But just as Matt more eloquently said than I will, I wanted to just remember that, we want to keep the conveniences and the efficiencies of telehealth, but we're going through a healthcare transformation in how we deliver care. And think about when we went through that, when people didn't do house calls anymore and they started to go to clinics. Well, we gained some things, we lost some things. Maybe what we lost might have been, the connection to the extended family. But telehealth does provide us some opportunities to kind of get back there. Maybe it can improve care coordination better and engage the families more. The other point I wanted to make was that I think that it's helping to move us towards a different kind of payment transformation model, value-based payment for higher value services, or that's based on not just the visit or procedure. I've been hearing a lot of providers telling me, why should it matter if I seen the patient by video or by phone, but in terms of how much they get paid, they don't see why it should matter. So I think it's moving this discussion, helping us to move the discussion towards payment transformation that's really based and focused on patient outcomes and the health and the well-being of our patients.
Love it. Thank you so much. And definitely keeping it balanced. So let's move forward to talking a bit about federal policy. So, I may be a little bit biased, but we know that U.S. Senator Brian Schatz and his staff have been great champions of telehealth. It was an honor to work with him for a number of years on that. And really, I had no idea about telehealth until he really championed it. So many of us in the community have been watching federal updates closely about what policy changes are impacting telehealth. So I want to speak particularly to some of our federal policy experts, Dr. Koenig and Dr. Higa, about what changes have you seen during the COVID-19 pandemic that are promising in terms of federal policy, and what changes do you hope will endure? Dr. Koenig, let me turn to you.
Well, we've made some allusions to there being waivers, and so basically what that means is that there are federal laws in statute that define telehealth, and they specifically bar reimbursement from Medicare for patients who are in their homes. And those laws are still on the books. It's actually in the Social Security Act. It's in federal statute that, number one, the patient has to be located in a Medicare eligible facility, meaning a clinic, hospital, or a skilled nursing facility. And that facility needs to be in a rural community as defined by the federal government. And so those laws are still on the books. there was a non-enforcement waiver that was passed at the beginning of the pandemic. And as long as the public health emergency is in effect, that waiver is in place. As soon as the PHE ends, that waiver will end and we'll go back to enforcement of the existing statute. And so we talk about it being here to stay, but if Medicare, which might represent 20 or 30% of the payer mix for a clinic, no longer pays for telehealth to the home, then that's a big problem for the continuance of telehealth for our seniors. People over the age of 65 who have become used to being able to have access to their physician from their home will suddenly not have coverage for that anymore. And so, call your senator, call your U.S. senator, call your congressperson. It will require a law to be passed. The U.S. Congress will have to pass a law to amend the Social Security Act in order for reimbursement to continue. And I think the good news for us here in Hawaii is that, as Aimee mentioned, our U.S. Senator, our senior U.S. Senator, Brian Schatz, is the co-chair of the Senate Telehealth Caucus. And so he has really an outsized role as a proponent for telehealth. I think we do have a voice in getting laws passed that will allow telehealth coverage to persist in Medicare. And that's the big focus for us.
Yeah, thank you very much. And I also want to mention Senator Hirono on the Senate side, and also both of our representatives, that they've all been really big champions on both telehealth and addressing digital equity divides. So we truly appreciate our federal lawmakers that are helping us to expand telehealth and healthcare in Hawaii. Christina, let me turn to you.
Thank you. I actually don't have too much to add, but just to reiterate, what we're really keeping an eye on that was lifted during this public health emergency for Medicare was specifically the location of the patient. They can be at home in an urban or rural area, the type of services. So CMS doesn't reimburse for all types of services. There's a list. So we're tracking that. And also the eligible provider. Not all providers can provide telehealth. Right now, under the emergency, anyone that can bill for Medicare is able to bill for a telehealth service. Whether the service is on the list or not is another question. So it's still very convoluted. It's not straightforward, but I do support what Matt said. We have an opportunity. He's really taking the lead to help everyone, healthcare providers in Hawaii, to look at their utilization data, make a case, understand what happened so that we can have information that can help feed into these policy decisions.
Yeah, excellent. Thank you so much. That's going to be really important to make the case. As we know, there's the Congressional Budget Office that kind of stands in the way sometimes from letting different statutory changes go through. So I want to change now to a really important topic as we're thinking again about going forward in telehealth, which is internet connectivity and bridging the digital divide. So we know that this is actually internet connectivity, interestingly, in the Aimee survey, was both an area of strength, but also an area of challenge. So we do know that there's a number of areas across the state that may not have the internet capability they need for both healthcare and for education, as we've seen. So there's a broadband HUI, some of us have been part of, and I just want to let Dr. Higa just speak again about that, and then I'll turn to Dr. Buenconsejo-Lum.
Okay, thanks, Aimee. So yeah, the lack of broadband has just been highlighted during this pandemic. Because if you think about it, if you don't have good connectivity in your home, your children couldn't go to school. Some of us teleworking was in and out, and now you have limited access to your healthcare. So it's now become an issue of digital equity all across the board. And this is really a very difficult problem to address because it's so systemic. It involves technical infrastructure and investment. But even if you have the infrastructure, then the families may not be able to afford the broadband plans or the devices. And then you have the issues of digital literacy. So it's really difficult to address this issue. Some of the ways that we can look at how to help your families and patients is looking at some of the federal funds for getting discounts on your telecom services, and there's some state programs and carriers that are also providing discounts. But we're also looking at innovative ways to get telehealth to places where they're not broadband. So the idea of Wi-Fi on buses, mobile telehealth clinics going to the communities, telehealth access points where there are not enough patients oh gosh, sorry. There are not enough patients for all the providers that they can share a kiosk, with a community health worker support, for example. We also look at encouraging the multi-purpose use of different programs. So we learned that, the devices that are issued by the Department of Education to school children, that they're allowing those devices to be used for telehealth when they're available in the home. So that's really important. And then the final thing that Aimee mentioned, I wanted to talk about the broadband Hui. It's an informal group, about 50 to 60 people that meet every Wednesday, and they have met every single Wednesday at the start of the pandemic. It's led by Bert Lum from DBED, and includes all kinds of people from legislators, educators, telecom carriers, healthcare representatives, nonprofits, community engagement groups. And the group is not funded, it's really informal, but collectively they're working on broadband mapping, putting together a digital equity declaration for the state, and other strategies to help us achieve digital equity in Hawaii.
Thank you. Dr. Buenconsejo-Lum, can you add to that?
Yeah, just briefly, thank you, Christina, for that very comprehensive list. And so I think the other piece of all of these great efforts is just to also make sure that the community is directly involved in this. And so through the broadband Hui, yes, there's representatives from our neighbor islands and Native Hawaiians and Pacific Islanders and many others, because it's actually important that there's representation from those who may actually be having the most trouble. A bit of a reality check, shall we say. And so there's also a lot of work being done with the libraries to increase access. So yeah, lots of good work starting. Has been going on starting, but we'll need to really continue this pressure going forward.
Thank you all so much for a fantastic panel. It's been an honor to hear from all of you, and I'm going to try to move seamlessly into Q&A. And actually, we have a question that comes right along what you've just been talking about. So the question is, does Hawaii PUC, I'm looking to you, Dr. Higa, on this, does Hawaii PUC have any universal service programs to ensure adequacy, accessibility, and affordability of broadband connections for telehealth, like the Federal Rural Telehealth Program and California's Teleconnect Fund?
Thank you. No, I don't think that we have a robust program like the California Teleconnect Fund. The state does have some requirements for universal service and access. And as I mentioned, what we've been hearing about are the various programs that the telecom carriers, maybe it is through a PUC program, but the various carriers are providing to provide discounts to eligible households that meet certain income requirements. And it's not just telephone, but also some broadband discounts, as well as mobile phone discounts. So before it used to be plain old telephone discounts, but now that's expanding.
Great, thank you so much for that. I want to ask a question. I hope that our viewers today have been excited about telehealth, have seen the potential for collaboration, and are really intrigued at how they can get involved going forward to both partner with UH and in the community to advance virtual care in our state and in the nation. So I'd like to turn to each of you and just hear, what do you see in your vision for how can UH and community partners collaborate going forward to advance virtual care? Let me start with Dr. Buenconsejo-Lum.
Thank you. And Jean Schneider also put a question into the chat, which relates to this. So yes, I think that, there's going to be a lot of impact on future health workforce and training and the role of community health workers. There are actually some small pilots that we're starting with Auntie Jessie and Ka'u Rural Health Association do pre-COVID, but really, training community health workers, but then also making sure that they're trained again in telehealth. And so I think we're going to need to see an expansion of that. And then again, with our many of our nursing students, I think our social work students, our medical students, I mean, this is all going to be something that we definitely, will need to plan for and in fact are planning for.
Yeah, thank you so much. We have been certainly hearing that from the community, from our community health centers, that kind of support in the community, whether it's a community health worker or a medical assistant or a health IT person, somebody that can go out and help seniors or others set up their equipment, maybe use a remote blood pressure cuff, or other to help to facilitate the visit. That may look like some of the workforce of the future that we at UH are pleased to be part of. Let me turn it over to Dr. Wilson to hear your thoughts.
Sorry, unmute myself here. So I do think that, just kind of taking into perspective what was said on the panel today, I think that the future of telehealth is it's going to be based on what the consumer wants. If they feel that it's a valuable experience, then I think that they'll continue to push for it. So I would say if the consumers feel that telehealth is, again, a good tool to get your healthcare delivery, then that's what we'll be looking for, and we'll align the technology and the broadband capability within that. But if they don't see the value in it, to what Dr. Koenig had mentioned, then it's going to be really hard to kind of push things forward. But I do think that this may be, hopefully that the pandemic is coming to a close, but I think that just wanting to be virtually connected is something that will go forward in the future. So I would just say that from a consumer perspective, if this is something that you feel that it's a valuable tool for your healthcare, keep pushing for it and keep supporting all of these great efforts that everyone has done across the state, all the way to Washington, D.C.
Perfect, you hit on it. And actually, let me just follow up and ask you, Dr. Wilson. So if I'm a consumer or someone else is a consumer that really loves their telehealth and is concerned, as has been stated, that this genie could go back in the bottle if some of these restrictions aren't lifted, what are some of the things, how would you suggest that a consumer get involved in expressing his or her desire to seek telehealth continue?
Well, the first thing would be to tell your physician that you really like your telehealth visit. Sometimes patients just don't understand just their advocacy towards their physician, and asking for it and wanting it does change a lot of the physician's practices, especially if you can attract patients by having this offering. And then, as mentioned, get involved in your local legislation, get involved in these small committees and groups, because together, all of those groups collectively will bridge together and make that next step and that incremental change. So don't be afraid to get involved, and don't be afraid to tell your physician that you really want telehealth and that this is working for you, if it is indeed working for you.
Excellent, thank you. So for those of you who are listening, certainly I hope you feel like you have ways that you can engage on this. Let me turn to Dr. Koenig.
I think Dr. Wilson hit it on the head. So I use the phrase, ask your doctor if telehealth is right for you. And I think that's really the message, is that there's consumer demand of saying this is convenient to me and it's timely, and it provides me access, and I value it. So I would like to do my visit by telehealth. But then it's really up to the physician to determine if it's clinically appropriate. Not everything is clinically appropriate to be done by telehealth. And so it's really a conversation between the patient and doctor about whether telehealth can meet the needs of the patient.
Got it. Do you mind also speaking, I know, just to reiterate, Dr. Koenig, about the policy piece, how folks can get involved going forward?
Yeah, I think, I think there's clearly an advocacy need. I think that our local delegation here in Hawaii, we're fortunate. I mean, I wouldn't say rest on your laurels, but I think our delegation gets it. But there's clearly a federal advocacy piece that the public can interact with. And I think at the university level, the need is data, and that's to kind of circle back to one of your earlier questions about what can UH do in this push. UH is where the researchers are, right? It's where the scientists are. And so, the ability to look at what happened during the pandemic, when all this very rapid adoption of telehealth took place, and look at the numbers and data that come out of payers, insurance companies, healthcare organizations, and did telehealth benefit patients? Was it safe? Did it replace the in-person visit, or did it just drive up the cost of care? Those are questions that UH sits in a unique position to answer, because that's where the researchers are, right? And UH interacts with the payers and it interacts with the Department of Health and the healthcare organizations. So the school is really in a unique role to help provide data that that our delegation can then use to kind of fight off the CBO and saying, look, telehealth was safe and it benefited patients and it reduced the cost of care, if that's what the data shows. So I think that's what we can do as a state that would be very, very powerful.
Excellent, thank you so much. And I think convening that HUI that I think Dr. Higa will speak about, it can be helpful with that in terms of partnership with UH as well, in addition to that convening role that you mentioned. Dr. Higa, let me turn to you.
Thank you. Yeah, I think there's a lot of opportunity for the academic and public-private partnerships in this area. As I mentioned, there's several HUIs. There's a broadband HUI. It's welcome. Everyone's welcome every Wednesdays on Zoom. There's also the telehealth HUI, where we're looking at broader engagement, but also very focused engagement by telemedicine directors and payers to do that, as Matt mentioned, the utilization studies. So I was going to talk about, working with the UH with the data science, and that's a priority in a very big area. It's a huge opportunity to work with our researchers and faculty and students, as well as leaders in the community, to take a look at the data, analyze the health data, its cost, its clinical data, all kinds of data, big data. So that's going to be a really important opportunity. But I also wanted to touch on two other things. One is technical innovations. So I think that we could really look at these academic public-private partnerships to address some of these innovative solutions for broadband infrastructure, since digital divide is a big, grand challenge for us. And there's probably other solutions that we haven't even thought about, right? And I wanted to say, I'm just learning about the UH's Innovation Impact Challenge from the US Office of Innovation. And that is looking at how to come up with these kind of partnerships to come up with creative solutions, technical solutions. And it's not just broadband. I think all of us on this panel understand also that there's so many different telehealth platforms. That's a problem. So we need to figure out how we can have a better interface to all these different platforms without worrying about the investment of each healthcare system. So that's an opportunity. And then the last point I wanted to bring on that was the social science research. Matt touched on it too, that there's so much opportunity to study the human factor of everything that we have just gone through in terms of everything gone virtual and dealing with it even in our daily lives. So I think there's opportunity to understand the human behavior to better enhance our telehealth provider and patient experience.
Excellent, thanks. Dr. Buenconsejo-Lum, do you have something to add?
Just really quickly, one other point is that as we work on these public-private partnerships, there's also policy pieces in the workplace. And so it's not just the directly telehealth, but this is much more related to worksite wellness and making sure that the employees have time off. Well, now you can actually do a telehealth visit from your desk, and which makes it much more convenient for many, many, many workers. And so I think that's also something to get. So it's not a direct telehealth policy, but it's actually critically important because we're certainly seeing many of our patients really want this, and it's just so convenient. But their workplace is going to need to, allow that. So.
Yeah, excellent. Thank you all so much. We're really seeing how there can be work to be done, whether we know we have a diverse audience today. So whether you're from the business sector, you've heard, helping to allow your employees to have time to use telemedicine for their visits. They can actually keep them more productive and keep them at work. For the consumer, expressing to your physician or to your elected officials how much you enjoy using telehealth and asking if telehealth is right for you. And then also working with our legislators, both at the federal and state level, and working with data to try to advocate for the policies that we think are helpful. So those are just some of the themes, in addition to collaboration and building HUIs to get a lot of this great work done. Let me pivot probably to our last question. And thank you, Dr. Buenconsejo-Lum, for answering in the chat, but I think it might be worth bringing up to anyone who might want to answer, how are non-native English speakers supported in telehealth? And have interpretation services been provided adequately? Is there anyone that wants to answer that?
I would say no. So I'll give you the honest answer, and I'll say I don't think they've been supported adequately, and that's a big priority for us. So we actually just built the technology for multi-party calls, and so you can do a point-to-point call between patient and provider, and during that call, you can reach out and bring a third party in. And I think that's really, really important for two things. One is virtual family presence, the ability for family to remotely join during the visit with the doctor. And I think that's a value add, because that is not something that, unless your family is local and able to take off work and go with you to the doctor's office, that's a value add compared to in-person care. So if your family on the mainland can remotely join you by video by clicking a link and join that video visit. And then the other huge opportunity is language translation. And so we actually, at Queens, we just integrated our video language translation platform into our virtual home visit platform. And that's in our testing environment right now. We're actually testing it like this week, and it's going live very soon. So I think that's going to be a huge value add.
Dr. Wilson?
Yeah, I'll echo Dr. Koenig's remarks. We haven't caught up yet. I mean, honestly, listening to Dr. Koenig today, they're a little bit ahead of us. So I'm going to go ahead and poke our EHR vendor when I get back to my desk. But yeah, there is a great, there's a pretty significant divide there. And even for hearing impaired or visually impaired patients, all of that still needs to be considered in terms of offering a really good telehealth experience. So we're not there yet, but I'm hoping that through the iterations of software that we'll get there hopefully soon.
And I just wanted to add that we really don't want to have telehealth introduce more health disparities. So this is really important. And at the Resource Center, we're working with family advocates groups to hold focus group discussions with patients who have, who are hard of hearing or autistic spectrum, deaf, so that we can understand their experience and then understand the provider's experience and come up with some best practices as well. And happy to hear that there are tools out there. And Matt, I know you've been talking about language translation long before the pandemic. And so, these are things that is just being kind of reiterated now that everybody's using telehealth so much.
I think that's a great way for us to end. And I just want to really express sincere thanks to our panelists. Really, you have just some of the best folks in telehealth here in the state speaking to you today. And hopefully you've been catching a bit of the excitement that all of us have for virtual care and its potential here in the state as we work towards a more just, equitable, and accessible healthcare system in Hawaii. Thank you all so much for joining us today. Really appreciate it. Aloha.